Please inform me, huh?
We are live.
Yes.
So good evening, doctors and all the participants. Again, today we have another session and renowned program that is the Icons in Conversations with Dr. Ritu. So the topic of the program today is tips for internal iliac artery ligation, and our guest speaker is Dr. Rajeshri Madam. So before starting the session, let me introduce none other than Dr. Ritu Santwani Madam. Madam is the senior obstetrician and gynecologist, and she's the IVF founder and CEO of 360-degree Healthcare Studio in the multi-specialty hospital Pune. She's an infertility specialist from new ages, and Madam is the co-founder of board member of WSCG. Now I would like to introduce our today's guest speaker, Madam Dr. Rajeshri Katke Madam. Madam doesn't need also any kind of introduction, but it's my formal responsibility to introduce Madam. Madam is a senior academician and the member of various committee. Madam is the professor and unit head, worked as a member of department DQSC committee member of maternal mortality, and worked as principal investigator ICMR HRCC JJH, and she is the state PCP and DT committee member at State Public Health Family Planning Department. Madam has many. Yes, ma'am. So, Madam has many research publications, also more than 100 of research publications, out of which 240 plus citation in many national and international journals, and many contribution to book chapters and many more in terms of Focus International Publication House. And Madam also received many awards and appreciation, a recipient of many awards, appreciated by the General Secretary of United Nations, Hon Ban Ki-moon, work in women's health, World Record of London Committee Certificate, Mumbai Achievers Award, Wahimi Puruskar, awarded from Chief Minister with Mahayogi Camp's Mahila Ratna Award, and Best Superintendent Award and Best Associate Professor, Rajiv Gandhi Excellence Award. And in terms of administrative experience, Madam has also a vast experience on that. So with this short introduction, I request Dr. Ritu Santwani Madam to take over the session for further proceedings. Thank you very much.
Yeah, thank you. Thank you.
Thank you, Dr. Suman, for the introduction. Thank you, Shield Pharma, for providing the platform for this series. So friends, as we all believe in this motto that knowledge is always increases by sharing, the same motto and same feelings I am having with my dear friend, Professor Dr. Rajeshri Katke. Dr. Rajeshri, a very, very renowned name. We can say she's an ocean of knowledge. She is professor and head of the unit. I know her schedule is very, very busy, but she is also very keen for the knowledge sharing. So whenever I tell her, Dr. Rajeshri, you have to take one talk for this program, in spite of her busy schedule, she never says no to me. So I can say I am blessed to have such a good friend in my life. And today, Dr. Rajeshri is going to discuss with us a very, very important topic, the tips for internal iliac artery ligation. The thing where I also want to learn some tips from her, because she is the master blaster for all this. And we all know I have done so many programs with her, all had gone super hit, because her programs, what is the talk she is taking, that is all the practical based. So what are the problems we are getting in the practical, in our day-to-day practice, on the different topics? So we are going to discuss that. So without wasting much time, now I'm handing over the session to my dear friend, Dr. Rajeshri Katke. Once again, Dr. Rajeshri, आपका तहे दिल से स्वागत है.
Thank you so much. Thank you, Dr. Ritu. She herself has developed as a faculty and a national and international icon in herself for the knowledge gaining, knowledge sharing, and making the people knowledgeable, and serving so much of the services extended to the the medical fraternity. And there is no words to give her works talent. I mean, the words will be short of that, what I mean to say, because, whenever we have to talk about her academic contribution, then it becomes like that, means what to use, what word to be used. So I'm really thankful and grateful. It's always a honor and privilege and pleasure to be with all this. And thank you, Dr. Suman, for the kind introduction. So we will touch this topic, and can I share the screen?
Yes, yes. Thank you, dear Rajeshri. We are honored to have you with us. Every time, whatever the sessions you have taken, because in this session, though you see in the Zoom, the participants are less, but most of the doctors who are joined from across the globe, they all join via YouTube. So I get lot of praises and lot of good comments. All of the topics what you have taken, especially the CA vulva was highly appreciated by all. So thank you once again. Yeah.
Thank you so much. We have chosen a very important topic of internal iliac ligation, because maternal mortality is one of the symbol, means to how the country is developed or the developing, and to prevent the maternal deaths, because the sepsis, hemorrhage, and the PIH, still it is the major, bunch of the maternal mortality, and these are the major causes. And we can prevent many things by, with the PPH and all. So let's have a look in that. So first, the history of the internal iliac ligation, by Kelly for the first time in 1893 for a cervical carcinoma case. This she has used ligated that vessel, and after that we are using it for the obstetric PPH. Let's have a look about the anatomy of the internal iliac vessel. See, it will be very important, because every I go to the workshop. We have done a cadaveric dissection also, and many youngsters, they are very keen, because this is one of the life-saving procedures. The internal iliac artery is the main vascular supply of the pelvic visceral structures. All the pelvic surgeons must know the anatomical landmarks, basic steps of the internal artery ligation in order to stop the massive pelvic hemorrhage. So basically, the learning tips with either with these all clinical reviews, these webinars, cadaveric demonstrations, and dissection, that will give the courage to go through with the internal iliac vessel ligations. See, I can talk on this because for 2 decades, we are doing this as a measure to control the postpartum hemorrhage. So let's have a look. See, this is very important. This is the abdominal aorta, where at L4, L5, it goes into the common iliac artery, and with the common iliac artery, it goes around 4 to 5 centimeter. This goes to the external iliac, which is a anterolateral. This is the infromedial part of the internal iliac artery. And when it comes, the trunk comes, see, this is the posterior division, which has the branches of the iliolumbar, laterosacral, and superior gluteal. This is very important to know, because it has its own application when we are ligating it. And this is the anterior division, which gives, we know that the anterior division goes with the obliterated umbilical artery, then the obturator, uterine will be there, then superior vesicle, vaginal, inferior vesicle, then this is the internal pudendal and the inferior gluteal artery. This goes to the, most of the muscles of the buttock and the perineal muscles. So it is very important how it is going in that, and this will be very important to know how to go ahead with that because this is one of the life-saving measures still, in cases of the PPH. So these are the branches I've just explained, but just to know that posterior division have a iliolumbar, lateral sacral, and the superior gluteal artery. Anterior division, internal pudendal, inferior gluteal artery. See the vast blood supply to the somatic and the pelvic viscerals. Then the obturator artery, uterine artery, middle rectal artery, vaginal, and superior vesicle and inferior vesicle. So I have shown in the diagram all these things. That means it is definitely covering a large bunch of the area of the pelvic viscera, and that has to be, once there is a PPH, that has to be, you have to circulate the other arteries, and you have to just like it the anterior division. See, this is the things from my OT. This is the we have seen it. Let me see that this is the common iliac. Why we say that na it should be like a V, like or inverted Y. So this is the common iliac, and this is straight which is going anteriorly. This is the external iliac artery, and this is going into the internal iliac artery. So ureter crosses at the bifurcation from the lateral side, it goes to the medial fold. And this is the external iliac vein. Why it is important? Because when we are ligating, how to prevent the complications. So this is very, very important. Just remember that this is inverted Y, this is the common iliac. After the bifurcation, it straight goes to the external iliac artery. Inframedially, it goes to the external iliac vein. Internal iliac artery, and the internal iliac vein is just beneath the internal iliac artery, and this is the external iliac vein. So this is from the dissection from the from our operation theater. So I just explained it very nicely how to go ahead with that. So the aorta is divided into left and right common iliac artery, the lumbar vertebra L4, L5. After a pathway of 4.5 centimeter, the common iliac artery gives the branches to the external iliac artery. So this is very important. So what happens? The internal iliac artery runs inframedially after the pelvic brim has two divisions, posterior and the anterior. The anterior division starts after 3.5 to 5 centimeter from the origin, and the branches of the posterior division diverge before that. See, this is the thing what I would like to tell you, that whenever there is a bifurcation, after that it goes to the straight way, the external iliac artery is going in that laterally. Inframedially, this is the internal iliac artery is going, and around 3.5 to 4 centimeter of that. Before that, the first is the posterior trunk, which gives the branches like iliolumbar, laterosacral, and the superior gluteal. These are the branches that has been left. So you should not ligate the internal iliac artery immediately after the bifurcation, but you should go around 3.5 to 4 centimeter below that, so that the posterior division will get excluded, and you will definitely ligate only the anterior division. So this is very important anatomical landmarks to know. Then this is I am explaining on the, this is from the B. Lynch, he has written an article, very nice article. So this is the common iliac artery. See, this is laterally, it is going to the anterolaterally, it is going the external iliac artery, and it continues as the femoral artery. This is the internal iliac artery, and what I was talking in that, after bifurcation, just it comes down, and the posterior division it goes. And this posterior division, it gives the three branches like iliosacral, iliolumbar, lateral sacral, and the superior gluteal. And what happens to the anterior division? Then it comes down, and then it gives the branches. So you have to tie it. But if you tie it here, what will happen? Both the trunks will get occluded. So that is not good, and it will develop the complications. So definitely this is the point where you should go, and that I have shown you on the live picture also. So what are the indications? Generally, internal iliac ligation, the main aim is the control of the bleeding when it is happening at the postpartum hemorrhages. So either you have to do the prophylactic or the therapeutic. So prophylactic, the same will be, there will be very difficult to, say that what are the indications, because in the prophylactic also post-abortion bleeding, PPH, atonic uterus, placenta percreta, accreta, where you can see that there is a high risk for the recurrent postpartum hemorrhage. That time you have to click in the mind that you should do it with the prophylactic internal iliac ligation. The therapeutic ligation may become necessary. See what it happens. Suppose we have done for the atonic PPH, we have done a cesarean section, and patient has gone into the severely atonic PPH. It's not getting controlled in that. Then second is the base of the broad ligament, hematomas. There are the broad ligament, either rupture or the hematoma formation. At that time, the bleeding is continuous. Consider for the therapeutic application. Then when there is a profuse bleeding from the pelvic side wall, we have seen such cases. Every obstetrician is going through all these cases, and they are saying, and it is a nightmare for the obstetrician. When there is a profuse bleeding from the angle of the vagina, when there is a diffuse bleeding are present without a clearly identifiable of the vascular bed, means you are not able to pinpoint from where the bleeding is coming, then you can go for internal iliac ligation. In the case of the rupture uterus, in which the uterine artery may be torn at the site of its origin. When there are additional indications including atony of the uterus, where all the conventional methods they have been failed, and second is laceration, extensive laceration of the cervix, or there is a very significant bleeding from the lower part of the broad ligament. Suppose if you take a case of placenta previa, adherent placenta, morbidly adherent placenta, placenta accreta, percreta, or if there is any trauma is there, or gunshot wounds of the lower abdomen, definitely it's a very rare thing. In the case of fracture of the pelvis and the intraperitoneal hemorrhage. So these are there is a very thin line to go into the therapeutic and the prophylactic ligation. So you have to judge as an individual case. Then comes to when there are the additional indications, including the atony of the uterus with conventional methods have failed, like extensive laceration of the cervix or the bucket handle tears. I mean, they are not, the bleeding is not being controlled. Then you have to think of that. In such circumstances, hysterectomy alone may not be sufficient to control the hemorrhage. See, we are the obstetrician, we have learned, we have seen, and we are in this field also. And here, if suppose you have done everything, obstetric hysterectomy and all, and there is bleeding, then we should go with the internal iliac ligation. So that is the one important thing. And on weight, the indications like uterine atony, uterine laceration, rupture, abrasive placenta, or placenta accreta, increta, percreta, cervical pregnancy. Sometimes it's very difficult to get control all these bleeding. So, so we have to think. So now we will see how this internal iliac artery ligation will definitely control the bleeding. See what it happens during a massive pelvic hemorrhage or peripartum bleeding. Bilateral ligation of the internal iliac reduces the pelvic arterial blood flow by 49%, but the pulse pressure will get reduced to 85%. So what happens when the pulse pressure, it goes down? So the arterial, the arteries, the vascular compartment converts like a venous blood, and in that the pulse pressure will be reduced, and there will be a stasis of the blood or the thrombosis, and that can occlude the blood flow. The mean pressure remained more than the venous pressure, but the triple hammer effect of the arterial pulsation was abolished. And this is very important because this reduction in the pulse pressure permits the effective thrombosis to take place, small vessels to stop the bleeding. After ligation, and there is a formation of the clot is there, and that will remaining in places unless it was mechanically wiped away. So it is very important to know that. But the internal iliac artery, whenever we ligate also, prominently the collateral circulation is also functional. It starts from 45 to 60 minutes after ligation, and within 24 hours also it can develop a very good amount of collateral circulation. So this is the very important thing. You should know that how it works and how it is effective in cases of the obstetric hemorrhages. With bilateral ligation, what happens is that 77% the blood flow will reduce on the same side, but for opposite side the effect will be on 14%. So generally there is a say that always it is effective also, and it is accepted worldwide also. Bilateral uterine ligation, the rate of the blood flow will be dropped about more than 50%, and that gives rise to the stoppage of the hemorrhage. So whenever we can see that unilateral or bilateral, the studies have shown that in a PPS, the reduction of pulse pressure may only be achieved in 48% of cases. It is for this reason that other workers have advocated the bilateral ligation of the internal iliac arteries to significantly improve the chances of reducing the pelvic pulse pressure and facilitate the hemostasis. Because once the patient is open, then you have to go ahead with and see that the hemostasis is completely achieved. So what happens in the reality? The hypogastric artery distal to the point, suppose if you are ligated, it is never emptied of the blood because of the rich anastomotic networks. That's why it is, if suppose like we ligate unilateral and it develops again the collaterals, then it becomes very difficult, to control the bleeding or the oozing of that part is there. So always go for the bilateral internal iliac ligation. Just a word about the collateral circulation. So this is the anatomical, everybody knows about this, but just see how it happens with the, some of the vessels, they are directly coming from the aorta, external iliac and the femoral, and with they are developing with the collateral arteries, like ovarian with the uterine, superior rectal with the middle rectal, lumbar arteries with the iliolumbar, vertebral arteries with the iliolumbar arteries. External iliac also, they give the very good collateral circulation in the form of the deep iliac circumflex artery with the iliolumbar artery, or the branch of the obturator artery with the inferior epigastric artery. And with the femoral also, we are going with the medial femoral circumflex artery and the obturator artery, and the lateral femoral circumflex artery with the superior gluteal artery. So you don't have to remember so many of that, but only the one of the word which can help is that even after the ligation, there is a definitely development of the collateral circulation that is helpful for the purpose of the even preservation of the fertility in cases of our young patients. So how to go ahead with the, what are the approaches? See, there are two approaches mainly. One is extraperitoneal, second is the intraperitoneal. In intraperitoneal, you can go with the anterior approach with the cutting of the round ligament, and second with the going with the pouch of Douglas. So what happens with the round ligament? You have to clamp and divide the round ligament. Then the fold of the peritoneum, when you have incise, always go with the, either a scissor, or if there is a bleeders are there, you can use the cautery also. I open with the cauteries also. So, and the loose areolar tissue, it goes away in that, and you have to just see where the bifurcation is there. But generally, when you are going through that, go it very nicely, even with the slight fingers, you can separate it, because if, that touch is very important in that. If artery is there, you can feel the pulsation of the artery, and in that, and you have to see definitely in the medial part of this fold, you will get the ureter, that we will see in the picture also, and I'll explain very nicely in that. So this is the uterus. This is the uterus, and this is the round ligament. These are the cut end of the round ligament. When you cut in that, you will go into the fold of the broad ligaments, and then you will go into the retroperitoneum. The external iliac artery is seen running a straight course, and it gives the blood supply to the lower limb, where it continues as the femoral artery. The external iliac vein, which is much bigger in caliber, is seen below the external iliac artery. Why we should learn in that? Because doing an internal iliac ligation artery, you have to know a surgical anatomy. You have to be very careful not to damage the vein, not to damage the ureter. So this you should understand in that the external iliac artery and the internal iliac artery. So external iliac artery is seen running a straight course, and it is going and continuing as a femoral. But the internal iliac artery, it goes to infromedial. That I have shown in the picture also. And that is very important, because accidentally also we should not ligate the external iliac artery. If we don't ligate the internal iliac, it's okay. But ligating the wrong vessel is very legally it is also not very viable. And second thing is that even the patient will have many problems because of this ligation. So we will see that when we reach when we identify the external iliac, internal iliac, then go 3.5 to 4 centimeter below that, then you have to pass a mixed, and then you have to we will show in the video in that, and but let me complete with this, and then you can fade it, and definitely you have to just pull it and ligate it. So that is about the how you should go with the cutting of the round ligament, and then you are going with that, and posteriorly by opening with the pouch of the Douglas. Okay. So if these are the some technical points, see, this is very, very important, because this is the experience of the 2 decades which I have compiled in this thing, which are the very important. If the arteries are difficult to find, feel for a pulse. This is the very important thing for a surgeon, that when we open it, that touch feel is with our fingers, you know, which we will never get either with the endoscopic or the robotic surgeries. Okay. So this is that you can say na, these or 10 fingers are like your 2 eyes and 1 brain for the obstetrician and the gynecologist. So feel for the pulse. Don't get panic whenever there is a PPH is there. If your feeling is that the bleeding is not getting controlled, ask for the help, ask for the blood, see for any senior is available, take for the assistant, and once you enter, don't get panic in that. Suction continuously to be done. See for the any bleeder is there, and that bleeder you have to cut it and you have to ligate it. But in a hurry, when the field is so much of the clotted, blurred, or if there are bleeding is more, don't catch any structure blindly. First, clean the space, identify the structure, and then you hold it and don't ligate it until you are very confirmed. These are the very surgical, important surgical tips, not for internal iliac ligation, but for any surgery. Okay, the surgeon has to be carefully not to ligate the external iliac artery or the ureter crossing the bifurcation of the common iliac artery. Though the 3 structures are easy to identify, one might end up passing the ligature around the wrong structure of the moment. We should feel the femoral pulsations and check the color of the urine immediately afterward. And these are the tips, and we will again, this is the, I have told you, the surgeon should hold the fold of the peritoneum in the pouch of Douglas, and the uterus can be seen transperitoneally. It is the same procedure what I have explained. Anteriorly, you can cut the round ligament, go into the fold of the peritoneum, go with the anterior and the posterior fold, see for the bifurcation, see for the ureter, identify the internal iliac, and then you go ahead with the procedure. The same procedure, open the peritoneum fold of the pouch of the Douglas. The assistant should hold the uterus, you know, if it is a big uterus, then it should be anteriorly, and the pouch of Douglas should get cleared. And here you can again open the fold of the peritoneum and identify the structure, and you can ligate the internal iliac artery. Extra peritoneal approach, some people they are doing it, and but I am not doing it with the extra peritoneal approach. But this is also same. You have to reflect the peritoneum medially, inframedially, and you have to you know, after fat and subcutaneous tissue are dissected away, gently reflect medially the peritoneum together with the ureter, identify the vessels, and then you can ligate it. So there are some important tips. I hope this is very vital. I mean that, but I would like to tell all of you, yeah, those who are seeing this, the ureter crosses the common iliac artery at the level of its bifurcation. This is very, very important. And incision is made infralaterally and parallel to the ureter. See, never do a you know, a transect or the transverse incision. Identify the peritoneal flap and see the ureter. You can see the ureter with its peristalsis, and this is a very important thing. When you will see the peristalsis, you identify the ureter. Then you retract the ureter medially. Then you can identify the internal iliac at the point of its bifurcation into the anterior and the posterior division. It is extremely important not to damage the internal iliac vein, because just beneath the internal iliac artery, the internal iliac vein is there. I have shown you in the diagram. So then you have to go. So just the anatomic relations, where you can see in that the anteriorly there is a fold of the peritoneum, medially the ureter, the internal iliac vein, again it is a inframedial, laterally psoas muscle and the obturator nerve. So this is yeah, this is from my this thing. see, this is the fold of the broad ligament, you know, I have opened it. This is the tube, and it is very difficult. This case was there. I hope if you can elicit in that. So this is the fold of the peritoneum. Can you see? This is the, see, I am seeing the pulsation. I am showing to the students, this is the pulsations, and the tissue was very much, see, can you see? Appreciate very nicely. Peristalsis, okay? So laterally it is going the thing. So I am just opening the peritoneum just to show the students with the mixture that there is a, this is the ureter. So lateralize the ureter. I am feeling with the finger the pulsation of the, you know, internal iliac artery, because we have excluded the external iliac artery to the lateral side. And if you can appreciate the vein is there, that blue structure is the vein is just beneath the artery. So this is the ureter, and in COVID I was operating. You see, this is the fold of peritoneum, ureter, this is the vein, and here is the, I am feeling the pulsation for the, you know, artery. So lateralization of the ureter is very important. This is the thing. So I am telling the student that this is the internal iliac anterior division after the bifurcation. So, yes. So now the important thing is that when you identified the thing, see, this is the bifurcation. It is very tough. The mixture, you have to make a plane in between the fascia, where the internal iliac artery, you know, adherent or depend upon the vessel. So we have to make the space with the mixture very slowly and very gently, and gently take the tip. Tip has to be forward, you know, anteriorly placed, you know, it is forward. So because if you don't, you know, you make your tip down, you can injure the vein in that. See, I'll explain you again. Okay. Very gently. Just open it, thread it, and take it out. This is a silk we have used. You can use non-absorbable, or some people they are using the Vicryl, but we are not using it that. But this you can take it. Okay. See, this is the case. I will explain you. The patient was very young. She came with so much of the hemoperitoneum, and I took a billing. Still, she was not able to, you know, stopping the bleeding. So I tied here. 1 minute, where it has gone. See, this is video. This is what it has.
Very nicely, Dr. Rajeshri. This is really very interesting.
This is actually क्या है ना, obstetric. See, this is the thing. Can you appreciate the peristalsis?
Yes,
here?
yes.
Yes. And can you appreciate the ligation?
Yeah.
Here the, yeah?
Yes.
And so neat and clean was the field in that. And I'll show you with the picture. This is the picture.
Yeah.
Where you can see this is the bifurcation, because when you are taking the video, you know, so many heads are there, and it was COVID also. And this patient, she came primi gravida with, PPH referred from everywhere. I took the B-Lynch, everything was there. The 50% of the blood loss has been reduced, but after that, still there was lots of ooze. And the relatives and the patient, patient was young primi, so it was very difficult for her to go for a hysterectomy. So I wanted to take all the things which will reduce the bleeding, you know, so that I can save the uterus for her and save her fertility. So what it happened is that, see here in picture, see, this is the divorce. This is the common iliac bifurcation. See how nicely the this thing is going, the external iliac straight. It is like an inverted Y or inverted V, you know. See, this is going, this is going here. This is the external iliac. This is the internal iliac. The posterior division has gone here, and here I ligated in that. Okay. And the ureter is crossing from the bifurcation we have taken in that, and it is going to the medulla, which we have seen into the this thing. So I think this should be the classical and clear picture whenever you have done it in that, So if you dissect the planes properly and do it very steady surgery, you can have such a beautiful and nice picture where you will not see any clots and anything in with this. So this patient, we have saved the uterus also. So we included it. So now what happens to the inadequate ligation of the external iliac artery? Sometimes there are cases where we have heard, we have seen also, there the external iliac artery has been ligated. The surgeon, how we should avoid in that? One is a perfect anatomical knowledge. Go for identify the internal iliac artery, see for the pulsations, because the internal iliac artery goes down inframedially, and external artery, if you feel that somebody accidentally inadvertently ligated, then there will be ischemia of the leg, limb loss. These are the risk factors in that. If it is ligated and if you identify it, the ligature can cut immediately and check for the adequate flow. If the artery has been transected, then it leads to the vascular surgeon and grafting and all those things like that. Okay. The classical signs are whiteness or pallor of the foot, of the distal pulses. This will be gives the idea about the status of the external iliac. But what it happens in that, in PPH, already the patient is in a hypotension, these things. In that also you will get a pallor of the foot and all these things. But here you have to check, you tell the anesthetist or tell the assistant, you have to check for the femoral pulse even with the dorsal spadies. I have never ligated one artery also without checking all this. And nobody should do like this, and nobody does like this also. But still you have to be very, very clear that and see for the Doppler signals at the using a handheld Doppler. So you have to confirm, you can take it, don't ligate it, hold it, plus confirm it. Here, the vascular surgeon, they apply the vascular clamp and they see for the femoral pulsations. We can also, if we have the vascular clamp, you can use here, you can see for the femoral pulsation and the dorsal spadies. Confirm with that. Here, I would like to say, I mean, it is a very nice and a very vital topic. I would like to say that once I was operating in a early morning around 3 a.m., 4 a.m., and the patient was open, patient was bleeding profusely, and I wanted to do the internal iliac. I was doing the internal iliac, and I was sure that it was the internal iliac artery. I identified the external iliac artery also. And then but I was not getting the femoral pulsations, some femoral pulsations, they are coming, they are going, they and all. So I was said, what has happened, because everything, and we have not ligated anything in that. We took the opinion of the vascular surgeon also, and in that also they will say, yes, that is the internal iliac and this is the external iliac, but still we are not getting the femoral intermittent pulsations. So here there was the disease of the, after that we have investigated, and here there was a disease of the aortoarthritis, and because of that we were not able to get the pulsation at the external iliac and the femoral intermittent in between. So for that purpose also, in that case also, to save the patient's life, we have surgically identified anatomically the internal iliac, and explaining we have ligated in that. Okay, and after investigation also we have found that there was a aortoarthritis and everything. So basically what I would like to say that you should be very careful, anatomically identify. See for the pulsation before ligating. Use of the Doppler. If you are in a doubt, take opinion. And because when the patient is, the abdomen is open, everything is there, always take an opinion. It doesn't get harm anything in emergency life-saving surgeries. In such rare cases, you can take it like that. Okay. So one thing I would like to show is that this is the how the ureter from the bifurcation. In my OT case also I have showed you. So this is how it is going from the lateral. It is coming into the medial field. Okay. This is common iliac artery. This is the internal iliac, external already it's gone in that. And what it happen is that you are ligating here. But once branch of the anterior division of the sciatic nerve is still here, and the ureter at the uterus. So these are the important structure. Do not ligate the branch of the sciatic nerve, otherwise the patient will have again foot drop and those things. So damage, suppose now we have seen, suppose the external iliac artery has damage, how you should go with that. Damage to the ureter. If you found that there is a damage, transaction of the ureter, do the stenting and all this. There is cut of the ureter is there, then anastomosis you can do in that. But if ligature, if you have found is that, then remove the ligature. See for the urine output. Always two things are very important. The pulsations of the femoral dorsal pedis, exclude the external iliac artery ligation. Then second important thing is that it do not catch the internal iliac anterior division, with bulk of the tissues, and take the, other important structure. Do not use the mixture, like downward face. So, don't push it. Gently hold the artery, either with the forceps, vascular forceps, put it down, and then you can go for the this thing for the ligature. Identify and then ligature. Prompt diagnosis and the remedial surgery by the urological colleagues is essential. Accidental ligature of one ureter may not lead to renal failure, but it increases the morbidity. Damage to the vessels, I have already explained to you. Steps to avoid to damage the iliac veins have been described in detail, but I have told you in that. See how the vein is very close to. The internal iliac vein is very close. I have shown in the diagram also, and in our in book picture also, atlas also, and in my OT things also in that. And we have seen in the video also how much it was very close. You have to just clear the fascia in between the artery and the vein. It is not very adherent, but in some cases you get a adherent, then you have to be very with the gently with the mixture, or if you required a little bit of the seizure, then hold the artery and then you can do it in that, but it has to be very meticulous. So suppose we have damaged the vein, how we should go in that? Don't get panic. What to do? You have to just press it, see to that, ask for the help. If you are competent, then never use a triangular or the cutting needle, for this thing, repairing the veins. Always use the either 3-0 of, polypropylene. People, we also use in that, and 3-0, you can take it out and see the two ends, the collapse the vein and take it and take the stitch. If you are not able to take it, keep it like that, ask for the vascular surgery. Yeah, if you are taking also, again, if you want to take the opinion, then take for this, because it has to be repaired with the properly, but don't get panic. Complications. Failure to remember the vaginal artery is a separate branch. So sometimes, the vaginal artery that also bleeds, and it is ineffective hysterectomy for the control of the bleeding. So injury to the external iliac artery, I have explained to you. Accident ligature or one or both ureters would lead to the renal functional impairment. Now, accidental incorporation of the anterior division of the sciatic nerve may lead to the foot drop. So these are the very important things in that. Rest of the infertility, buttock, thigh, claudication, damage to the ureter, buttock ulcerations, necrosis, gluteal muscles, because accidentally if you ligate the other arteries and all. So these are the things, bladder gangrene, but nowadays this doesn't happen. But there are a couple of cases we have seen with the buttock and the thigh claudication also. So this is for the thing. So what are the structure which you can injure in that? So injury to the external iliac vein, injury to the internal iliac vein, ligation or laceration of the external iliac artery, injury to the internal iliac artery, and ligation or laceration of the ureter. So these are the things. Then post-operative care, intensive care is necessary. Sometimes it may require the ICCU, large hematomas or collections are there. So we should keep 2 drains, then higher antibiotics. Early ambulation is very important in that. So just to enlist, this is not collateral. We have, so this is the thing. Just now in Navi Mumbai, there was a conference where I have shown the, this is the cadaveric dissection of the This I have shown to the people about how to go ahead with the internal iliac artery dissection. Anatomical, I went till I dissected till it to the obturator canal, obturator nerve and everything. She is Dr. Kavita. She is a professor HOD at this thing, Punjab, Haryana, some this there, and he is Dr. Anit, and these are the this is the one HOD madam, and these are the things where I was explaining, and they says ki it's a very good thing. So this is I was teaching to the gynecologist. All they have come to the workshop, and very nicely conducted workshop there, and everybody was very happy in that. So it is always a pleasure in that. So let's have a just couple of slides are there. So monopolar or bipolar electrocoagulation could also be used. If you are experienced, then you should go for that. Before ligation of the internal iliac artery, dissection of the ureter is very extremely important. At least you identify. If you don't want to dissect, it is different. But identify and keep it away from the before taking the ligature. Acha, So internal iliac artery, although ligation performed at any side of the patient, either right or left. See, this is very important point, because movement of the right clamp from medial to lateral will cause the laceration of the external iliac. So you have to go with the lateral to the medial. The common internal iliac arteries are often adherent to the underlying veins. See, I'm doing it. So sometimes you don't have to do anything. Easily the artery goes below the artery, that you get a space. It is loosely adherent. Sometimes it is adherent. Then you have to be very careful. Good retraction of the pelvic contents and displacement are needed to visualize the veins. Never do ki, no, I have seen this internal iliac artery, I should go. So don't hurry doing in that. These are the practical tips. Everything is in the books and everything is given, but these are the practical day-to-day tips. Means when you are doing this, you have to be very careful. Then meticulous dissection with the scissor is required. Whenever when you creating the plane, then find it out whether any abnormal course of any vessel is there or not. This is best done on the tip of the finger with the opposite. See, everybody develops their own skills. We always, I always put it and I support with the finger, because I don't want that it should damage the external or internal iliac veins. Simply pushing the forces between the artery and the vein in an uncontrolled fashion is very dangerous. Sometimes, see, now previously when I was junior, I used to learn what to do. When we become, then we learn what not to do. And that is how we develop our expertise with the learning curve. It is always advisable to try separating the artery and the vein. The peritoneum should be close with the, okay, this is just to control. This is for the embolization of the internal iliac artery. I just put it that you can embolize if you have interventional radiology. People are there which is attached to your operation theater or the labor room, and you can transfer. Generally, we do pre-operatively in cases of the percreta, arcreta, placenta, complete placenta previa, or erosion into one of the either bladder, peritoneum, or any that. So you have to explain everything in that. As a result, the triple hammer effect of arterial perforation is abolished. The surgeon must be aware that bilateral ligature of the internal iliac artery is more effective than the unilateral procedure. Potential failures and the consequences. The ligation of the hypogastric artery sometimes fails. When it fails, there is a massive necrosis, infection, destruction of the vessel wall, the presence of large aberrant branches feeding blood. Yeah, there is a dislodgement of the clots when the blood pressure rises, or there is a coagulopathy. The effect on the fertility, I think Ritu will agree with that. I have gone through the literature, but I have experience also, because I have done the internal iliac ligations on many patients, and there the patient has become pregnant also. So in my say, and the world literature says the reproductive capacity is not lost, but there are papers where they have say there is a low level of the AMH, or there is some amount of the poor ovarian reserve. They have mentioned in that, but generally many
Just
patients.
1 minute, Dr. Rajeshri.
Yes.
Dr. Sudha, will you please mute yourself? Lot of background noise is coming. So Dr. Rajeshri is sharing some very important points. So this technical team, can you please mute all other participants?
Yeah, madam, already muted.
Okay. Thank you. Yeah, Dr.
Very
Rajeshri.
important. And Ritu, will you please highlight on this effect on fertility?
No, that's correct. You have correctly mentioned. Yeah.
Yes.
Yeah.
Okay, so these are some references with the original B. Lynch, he has done, and there are some references and all that. So I would like to end with this Albert Einstein, what he says: a person who never made a mistake, never tried anything new. So there is always in a life, there is a learning curve. So we have to go very carefully, learn the things, practice it, and apply on the patients, because whatever we are doing on the living someone's living body. So whatever our things are there, with expertise we can save the life. And still now also, even with the internal iliac ligation, uterine, B. Lynch and all, the blood loss never it completely stops. And that time, sometimes again you have to do a life-saving procedure of obstetric hysterectomy. Still it is a life-saving procedure. So all these things you have to go, and you have to do it to give the better fertility future for all these young patients. And this is, I think, this is because this topic contained with the anatomy, the relations, because whenever anatomical relations, now people are not very much in the we are become so much of senior. I have gone also in that anatomy department after my first MBBS. So what it happens, so I took it out the important anatomical landmarks, important practical tips, how it works and how we should do. I think it will be helpful. And
very helpful.
Very much, Dr. Ritu, for thank you, Suman, and thank you, Shield, also giving the platform for the knowledge sharing. This is very important. So everything is given everywhere, but still we need the expertise just
very
to share
true.
the experience, because with experience people can that gives the more learning than going and reading the things in that. So I'll here I will stop my screen share.
Yeah, very precisely. Yeah, very precise. Just a second. Just a second. This is someone important call is coming. Just a second.
Yes. Ritu, Dr. Kavita is there. She is a HOD. Dr. Kavita, are you there?
Yes, doctor. I'm very much here. Can you hear me?
Okay. She's from where?
No, she is a HOD. Madam is professor and HOD.
CMC Ludhiana.
Okay. Yeah, welcome.
Dr. Rashri is my very close friend now.
Yes.
I'm not going to open my video because.
Yes. I know.
No issues. Thank you for joining, Dr. Kavita.
Thank you very much. And we have done the dissection, and Madam is a very good teacher. And she is very good clinician, and everything.
No, I'm still learning from Dr. Rashri.
What a big thing.
Dr. Rashri has taught us all about internal iliac artery ligation during the workshop and today also.
Oh my God, so nice of you. Thank you so much.
It's Madam. Like a revision, and we are also doing it here now. PGs also.
Yes. Now people are there, and it was a good initiative by include this by Dr. Mitra Saxena. It was very good, because she was keen also in all these things. So they chose me as a faculty also. So thank you to them also. And Ritu, this is very important topic. This is very life-saving, you know.
Correct. Yeah.
If we teach our young generation what are the important life-saving procedure, that this is the best thing what you have done by giving this topic.
Correct. That's why I told you, Naki, we will take this topic only. So this will be useful for so many of us. So if there are any questions, see, the lecture was such a nice, no questions have received. I am checking in the YouTube also. No questions have received.
Good, na?
Dr. Rashri has
That
explained
means
so
either
well.
lecture is good.
No,
Yes.
no, it very nicely explained. The video also was so good, Dr. Rashri.
It
Yeah.
was good, na, the ureter and all. Chalo, acha
Ah,
hai. So we can make
yeah.
another also in that. Generally, we
And-
go with the posterior approach and anterior if it is required in that also. Extraperitoneal, I have not done, I am not doing also. So, but many people, some people they do and they like also.
Chalo, thank you once
Thank
again,
you, Dr.
Dr.
Ritu, madam, and
you.
God bless you all.
Dr. Ritu, my motivation for joining today was Dr. Rashri.
Yeah, of course.
We will join Dr. Ritu, you know, she is, you must be knowing also, she is a national figure. And Pura Academics, she takes all the programs, good academics, and doing a very good work in a knowledge sharing platform.
Dr. Rajashri,
I can
you are
imagine.
icon for today.
Don't pull me now.
No, I'm not pulling. I told you, no, I'm blessed to have you as my dear friend.
Yes. And
Yeah.
Kavita, Dr. Kavita madam is also our friend. She is also very
Chalo.
good, very nice. If you will meet, both of you will meet, na, then
Yeah.
it will be very nice of that.
So
Yes.
friends should not be addressed as madam. Just
Yes, but this is the platform,
fine.
na.
नहीं, मैं तो राजेश्री बोलती हूँ, मैं तो कहाँ बोलती हूँ